Good morning. Thank you so much to the organizers for the opportunity to present today. This analysis was done in partnership with Fatima Choris, the Senior Director of Catalytic Innovation and Program Optimization at EGPAF, but only made possible by our broader EGPAF colleagues across our teams and countries who routinely collect and report this data. So wanted to recognize that. The title of the presentation this morning is Pregnancy and HIV Status Among Pregnant Adolescent Girls and Young Women in 8 EGPAF-Supported Countries. So to start with some background on the issue, which I think everyone is already familiar with in this room, but adolescent girls and young women are a high-risk group for pregnancy and for HIV. Pregnancy and breastfeeding are a high-risk period for HIV acquisition, both for the mother and for the infant. We know that timely and continuous engagement in antenatal care is effective in reducing risk of adverse events, especially among adolescent girls. And we know that the pregnancy and breastfeeding period, especially for adolescent girls and young women, they experience or often experience higher risk of complications, lower retention in antenatal care, and seroconversion risk with lower use of prevention options. We examined trends in antenatal care, attendance, and HIV positivity among AJYW and 8 EGPAF-supported country programs over time, including before, during, and following COVID-19 timeframes. So in terms of our methods, we used routine PEPFAR program data from 8 EGPAF-supported countries for this analysis over the timeframe of January 2019 to June of 2023. The countries include Cameroon, Cote d'Ivoire, DRC, Eswatini, Lesotho, Malawi, Mozambique, and Tanzania. Data were analyzed to compare quarterly trends over time, including specific timeframes concerning COVID-19, as you can see on the slide. And indicators of interest included the number of new ANC clients and documented HIV status at first ANC. And we disaggregated these indicators by age, so younger adolescents 10 to 14, older adolescents 15 to 19, and young women 20 to 24. And then also disaggregated by type of HIV status, so those with a previously known status and those with a new diagnosis of HIV. We also used a one-way ANOVA test for statistical analysis to compare aggregated proportions of AGYW as new ANC clients across countries between the COVID-19 timeframes of interest. Moving on to our findings, our data showed that AGYW, so those between 10 to 24 years, make up almost half, so 46% of all new ANC clients between our time frame of interest and across all the 8 countries, with the other 54% being adults 25 plus in the green bar on the slide. And in the upper right corner, you can see the proportion of new ANC clients by age, and we can see that young women 20 to 24 make up the highest proportion comparatively, with 29% among AGYW, which is consistently illustrated in the graph over time in the yellow bar. It is also important to note that some countries have larger proportions that are represented in the data. So these include Tanzania, Malawi, and Mozambique. So now we're going to take a look at ANC attendance over time. And just at an aggregate level, there were over 1.3 million AGYW that attended ANC over this period. This graph depicts the proportion of new ANC clients who were AGYW across the pre, during, and post-COVID-19 timeframes. The results of our ANOVA test comparing these timeframes showed a significant p-value, indicating that ANC attendance among AGYW varied significantly across the timeframes. Moving from ANC attendance to take a look at HIV status and positivity, our analysis shows that among AGYW who are new ANC clients, HIV positivity increases with age. So the graph on the slide shows this in the increasing HIV positivity with increasing age, with young women 20 to 24 having the highest percentage of AGYW living with HIV at 4.1%. So now we're going to shift to look at trends in newly diagnosed versus known status among AGYW who are living with HIV. So we observed that the proportion of new ANC clients with the aggregated proportion of pregnant AGYW living with HIV we observed that the proportion of new ANC clients with HIV who were newly diagnosed was highest among adolescent girls 15 to 19. So we can see this on the slide with the aggregated proportion of pregnant AGYW living with HIV who were newly diagnosed in ANC to be 49%. And so we can see that compares with young women on the slide, the last bar, which is 39%, and then compared to younger adolescents, 10 to 14, which is about 33%. And it may be important to note that it is likely that adolescent girls 15 to 19 may be coming to ANC for the first time. This is their first pregnancy, so they're also testing for HIV for the first time and are thus newly identified, compared to older groups like young women 20 to 24 who may be on their second or their third pregnancy and were thus previously tested and already have a known status. So that might make sense to see sort of more newly diagnosed in the adolescent girl age group 15 to 19. So taking a look at ART coverage over time among AGYW living with HIV, this graph shows the overall trends in ART coverage among this group, both known and newly diagnosed over time. And we can see that there is consistent coverage, especially post-2021, with a dip during early 2020 and the end of 2021, which sort of aligns with the COVID-19 timeframe. But thereafter, ART coverage improved and was sustained thereafter. The number of AGYW in ANC known to be living with HIV compared to those who are newly diagnosed in ANC does vary across countries and ages. The figures on the slide depict the three age groups, so younger adolescents, older adolescents, and young women, and illustrate the varied proportion of known versus newly diagnosed AGYW living with HIV who are new ANC clients across countries. And I think there's a few things to point out on this slide. I think the first thing to take away is the increased increments with age on the scale. So we can see for younger adolescents, it's in the hundreds, it goes up to the thousands, and then it goes up to the 10,000s with increasing age. The second, I think, is the high number of pregnant young adolescents, so those between 10 to 14, especially in Malawi and Mozambique. So something to be aware of and which warrants concern. And the third is just to highlight the variation across countries. So to give an example, we can see that for Eswatini, among young women 20 to 24, there's a larger proportion of pregnant AGYW who are new ANC clients who are known to be living with HIV compared to those with a new status, compared to, for example, Côte d'Ivoire, who have a pretty even split between those with a known versus a newly diagnosed status. Among pregnant AGYW in ANC living with HIV, there has been a modest decline in the percent of newly diagnosed AGYW over time. And this percentage remains higher in older adolescents, so 15 to 19, compared to young women. The top graph depicts this trend for those 15 to 19, so we can see this modest decline from 54% to 41%, compared to the lower graph, which depicts the same trend for young women, 20 to 24, also with a modest decline from 44% to 37%. So in conclusion, some key takeaways to summarize. Adolescent girls and young women between 10 to 24 constitute a high proportion of all women in ANC, with nearly 50% of all women in ANC being AGYW, and we saw this increase over time. The proportion of pregnant adolescent girls and young women with HIV who are newly diagnosed with HIV in ANC varies across ages and across countries. The proportion of adolescent girls and young women with HIV who are newly diagnosed in ANC modestly declined over time, with the highest among adolescent girls 15 to 19 years of age compared to young women 20 to 24. And I think this trend, or these trends overall, underscore the importance of establishing integrated HIV and sexual reproductive health services, including family planning and dual prevention options, targeting and tailored to adolescent girls and young women in ANC, also including those not living with HIV. Thank you very much, and thank you also to Linda, Laura, and Lynn for their guidance in this work.